There was deformity in 4 cases. In 2 cases, swelling had already progressed to a large size when the patient came in our OPD. In one due to post-operative fracture, the case that I already shown you, and in one due to epiphyseal damage. Now the limitations of our studies. Because of the relative rarity of these diseases, our sample size was small. A control group was not feasible because all the patients were treated identically. As there is no clear-cut criteria to judge incorporation of the graft material into the bone, it was impossible to compare exactly the ingrowth rate with that of other bone substitutes. Now I would like to come to the conclusion. It is easy to manufacture and preserve, and hence can be made available in abundant quantities, so the mismatch in demand and supply can be averted. It has not caused any adverse reaction like any allergic reaction. It has got excellent biocompatibility. There is no risk of transmission of disease. It can be used in pediatric population as well. Had got good adjustment of shape depending on the shape of the bony cavities left after curettage, and its biodegradation is very slow in the body, which allows proper time for osteoconduction, hence osteointegration. At last, I would say that the synthetic calcium hydroxyapatite is emerging as a very good and safe alternative of bony autografts and allografts in the treatment of benign and locally aggressive bone tumors. But the ideal bone graft does not still exist. The journey for the search of the same is still continuing. Thank you so much.
Thank you for your nice presentation. If any questions from the audience?
Etiology I have already shown most. No, etiology all the cases of. Yeah. No, all the benign or locally aggressive lytic lesions. Yeah. No, we were also went for. No, we also went for FNAC initially. Yeah, I have shown the management protocol.
Now the last speaker is Dr. Rohan. Dr. Rohan Bhimani.
Good afternoon, chairpersons. Today I'm going to talk upon is subdural and subarachnoid hemorrhage post-scoliosis surgery. It's a single case report. To begin with, we all know that post-operative subarachnoid hemorrhage following scoliosis surgery is a disastrous complication whose pathogenesis is still unclear in most cases. And very few cases in the past have been recorded with this complication. To just about the case, it was a 10-year-old male child operated for idiopathic thoracolumbar scoliosis with low-lying conus medullaris, for which we did a detethering with pedicular screw fixation from T3 to L2 with bone grafting and right costoplasty. On post-operative day 5, the patient developed convulsion and drowsiness, which he recovered subsequently by post-operative day 7. The details about the case: it was a 10-year-old male child, as I mentioned. He presented to us with complaints of deformity and pain in the back. Patient was moderately built and nourished with no significant neurological disorders. His basic parameters like HB was 10.3, ESR 14, CRP 30, with PFT suggesting of early type 2 respiratory failure. As I mentioned, the surgery that he underwent was detethering with pedicular screw fixation from T3 to L2 with bone grafting with costoplasty done. The surgery was performed taking all precautionary measures in form of Artline during the surgery. The total surgical time was 4 hours with an intraoperative blood loss was approximately 1.5 liters. But intraoperatively, there was an arterial bleeder which led to fall of his BP to 40 by 20 mm Hg, which was immediately brought back to normal in 5 minutes by giving whole bloods and colloid. The total CSF loss during the detethering was around 100 ml. And post-operatively, the total drain output was 300 ml over 3 days. On post-operative day 5, patient developed convulsion, and then after that we shifted the patient for CT scan, and which showed a subarachnoid as well as a subdural hemorrhage that the patient had sustained. Then we took an advice of the neurosurgeon, which he advised to give phenytoin for convulsion, and by post-operative day 7, the patient recovered completely without no neurological deficit. These are his preoperative X-rays, right bending. One more pre-op X-ray. This is preoperative brainstem picture, which is normal. This is immediate post-op X-ray. One more post-op X-ray. This is the post-op day 5 CT scan that we got it done, which shows a subdural hematoma, as you can see. A similar image on the CT scan of subdural hematoma, and along with it associated with a subarachnoid hemorrhage in the same CT scan. Moving on to the discussion part of this case, the intracranial hypotension associated with subdural hematoma is rare and can prove to be devastating complication, but it is a possible complication of procedures involving the dura. Intracranial hypotension is usually a benign condition. However, it can lead to subdural and subarachnoid hemorrhage because of laceration of the superior cerebral vein or arachnoid granulation. Although the exact mechanism is still unclear, it is highly indicative that CSF hypovolemia causes decrease of the intracranial pressure, which causes enlargement of the dural venous sinuses, which becomes an important factor in pathogenesis of intracranial hemorrhage. There is a downward brain displacement resulting from pressure can lead to transient stretching and occlusion of these previously engorged venous sinuses and thus disposes these patients to venous tears. There have been very few reported cases of acute subdural hemorrhage and subarachnoid hemorrhage after spine surgery. Most of them have been associated with intraoperative dural breach that have been reported. Usually such tears are readily identified by the surgeons on the table and they are closed intraoperatively. And similarly, such drastic hypertension intraoperatively should be avoided by the anesthetist as well, and if it occurs due to any cause, should be spontaneously corrected by them. Sometimes dural tear may go unnoticed or may be prone to rupture later, which may result in occult CSF leak and intracranial hypotension. This is a pictorial explanation of the subdural and the subarachnoid hemorrhage. Just moving on to conclusion, that we conclude that intracranial hypotension was the likely cause of subdural and subarachnoid hemorrhage in our patient. These are the few supporting literature that's available. Thank you.
So thank you, Dr. Rohan, for a very good case presentation. Now the case is open for discussion. If there are any questions from the audience. So we conclude this session. Thank you.
Thank you very much.
Thanks to all the speakers and thanks to the organizing team for giving us opportunity to share this session. I also thank my co-chairman, Dr. Ram Avatar, for giving me a good company. So thank you all. The session is now over. GBM is going to be there in Hall A. So all of us